to course 7, which is crisis intervention for addiction professionals. So we'll start. Let me share the screen with you for the curricula. Yeah. So for this particular course, I hope everybody is alert and you've had a one-day break. Hello? Yes, can you see the screen?
Yes, I can see it.
Okay, no, thank you. So we are going to begin our course 7, which I've already said is crisis intervention for addiction professionals. This particular course focuses primarily on crisis intervention and crisis management. In this course, we are going to define what a crisis is, and hopefully we'll have a consensus definition, because we know that a lot of people have definitions of what a crisis is. We are also going to describe steps to manage a crisis, so that as counselors, we are able to effectively help clients when they're experiencing a crisis. We are hoping that all of us at the end of the training for this particular course, you will demonstrate awareness of suicide intervention. What do you do when there's suicide, when your clients have suicide ideation, when they do have a plan? What type of interventions do you normally employ, or what are the ones that are recommended? We are also hopeful that you will also be in a position to have some knowledge about how to prevent suicide. And lastly, to demonstrate how to handle difficult or hostile clients while ensuring counselor and client safety, because a lot of times we think about the client, but we don't focus on our safety as counselors. So that is the main objectives of course 7. We are not going to take a break because we just started. Just as like all the other courses, I believe that we always come with expectations, and I'm going to ask you just to dot those expectations in our chat so that we see whether we meet your expectations after we've finished the course content. You can also just note those expectations for yourselves actually in your little booklets that we talked about at the beginning of this training, so that we see whether we've met your expectations. So it could just only be 2. So before I go to the next slide, I hope, Jessica, you will help me with this. I want somebody to volunteer to tell us how they would define a crisis before we jump into some of the consensus definitions that we have on the slide. How would you define a crisis?
Fatima, would you like to share?
Yes, just go ahead and tell us how you define a crisis.
Can I go on?
Yes.
Yes. I think crisis is something very strong that can really overwhelm a person. It can even incapacitate the person of him or her. Thank you.
No, thank you very much, Fatima. You've actually captured what is on the slide. A crisis is a perception, very important for us to understand that, or experiencing of an event or situation as intolerable, as Fatima has already said, difficulty that exceeds the person's current resources and coping mechanism. What I would hope that we pay attention to is the fact that a crisis can be a perception, and therefore it means that your experience of a crisis is subjective. So what might be a crisis to one person might not necessarily be a crisis to the person next to them, even if they are experiencing the same situation or they're in the same situation. And the other thing that we have to also pay attention to is the fact that the person actually feels that they do not have adequate coping resources or mechanisms to actually deal with the situation that they are in. Now, there are different ways in which we can define crisis, and here are some of the ways that we can conceptualize what a crisis is. But at the end of the day, they do have the same sort of stem in terms of understanding. One is it's a state of disorganization and confusion in which the client faces frustration and profound disruption in his or her life. What stands out there is that there's a profound disruption. There's sort of like somebody's not able to cope, and there is a disruption of what they currently were actually able to do. The other way that we can look at crisis is it's an immediate situation or short-term period when many emotions are felt: extreme uncertainty, fear, loss, and grief. I was just thinking in the morning as I was going through the slide that you can think about a crisis because of corona. Like there's some sort of disruption in our lives, and initially we had fear, we had anxiety, we had a sense of grief and fear. So that is how we can define a crisis. It also can be defined as an emotional state in response to disruption in the client's life, not the disruption itself. Very important here to understand that it's not the disruption or the event or the situation itself. It is how somebody actually experiences or perceives or feels about that kind of a situation that it makes it a crisis. It's not the disruption itself, and hopefully we do fully understand that. A situation, regardless of its magnitude, does not define a crisis, but how we respond to the situation or event constitutes to what a crisis is. So it's important for us to actually distinguish what is a crisis and what is not a crisis. One of the things that is not a crisis is when there's a problem, regardless of the magnitude of a problem, when an individual or a family is able to solve the crisis, regardless of whether it's worrying, whether it's big or small, it's not a crisis. And one would ask, why is it not a crisis? It's because if an individual or a family feels that they have adequate resources to actually attend to a huge problem, it will not constitute to the definition that we've already discussed about what a crisis is. So when a person or when our clients feel that they do have the coping mechanisms and they're in a position actually to deal with the problem, whether small or big, it is not a crisis. So the next slide also continues into talking about the conceptualization of a crisis. Here we see Chinese characters, and somebody could ask, why are we looking at Chinese characters? There is a point to make here in terms of a crisis and how it's actually symbolized in Chinese. There's a misinterpretation by many with regards to the characteristics of crisis. Some equate the characteristics of crisis in terms of symbol of danger and opportunity. However, even though that is a misinterpretation, for us as SUD professionals, it actually gives us an opportunity to look at the combination of danger and opportunity and how it relates to crisis and crisis management. So a crisis is danger. In what ways? It threatens. It can threaten or to overwhelm the client. More especially for clients in recovery, it can result in relapse. For clients who might feel that they do not have the resource to cope with an event or a situation, they might resort going back to using substances. That is why we see it as danger. How can a crisis be an opportunity? It's a platform or an opportunity for us as clinicians and as clients because it creates a platform where we can provide an intervention, and more especially for when a client is actually open to receive that kind of intervention. It's an opportunity to actually plant seeds for positive change and personal growth. For us as counselors, our role during a crisis is to actually lessen the danger and actually mitigate the danger, and also provide that opportunity for our clients to actually see that opportunity for growth, as I've already mentioned. So you can see how probably we are using the misinterpretation of many for looking at crisis characteristics and maybe linking it to the symbols that are used for danger and opportunity. For us is to see how do we take this misinterpretation to see how it really relates to crisis. We do have a small exercise here, which I would ask somebody just to give us an example. I know when we are in our different areas, we'll probably have more time to do that. But let me just have one volunteer to tell us how a crisis can be a danger and give us an example, and another person, or maybe the same person, tell us how a crisis can be an opportunity and give us an example of how that is an opportunity. Somebody volunteer, because I can't see the chat. If somebody can just volunteer to tell us how a crisis can be a danger, how a crisis can be an opportunity, and give us an example for both.
All right, Igator's hand is raised.
No, thank you, Igator. So go ahead.
Yes. Yes. Before you came to this group exercise, the moment you mentioned that crisis can be a danger, can also be an opportunity, a patient readily came to my mind. You know, there is this patient that is on admission now for about 2 years now. We've been he became known to us as a user of heroin about 2 years ago, and the mother has since been asking him to come for treatment. Sometimes he would come for 6 months, we will not see him again, and so on and so forth. But about 4 weeks ago, he took an overdose of heroin. And he had respiratory depression. He was so scared that he was going to die. He was the one who now told the mother, since he told the mother what he has done and the symptoms he was having, and he was the one who now told the mother, let's pack my things together. I want to go and see Dr. Higato. I need to go for treatment. So you can see the experience of this client just shows that yes, he took an overdose of heroin, which was a danger. He was at risk of losing his life. But now the man has been in treatment for about 6 weeks. His stage of change is different. His level of motivation is quite high. So that is what I just want to share.
No, yes. Thank you for sharing with us that life example. It definitely shows us that crisis actually creates an opportunity in that instance, or maybe that situation, or for that particular client. Obviously, it was danger. We can see clearly an overdose is obviously a danger, but it also created an opportunity for him to actually ultimately come for rehab. So we can see crisis in that manner, even when we are actually dealing with our clients, just so that when we think about crisis, it's not just danger, but we also have to understand that there's an opportunity for intervention. So that is the end of our module 1. So we are going to shift gear to module 2. Let me just module 2. We are going to focus our attention now on what causes a crisis. One of the things in terms, because now we've defined what a crisis is, we understand what a crisis is, what constitutes to a crisis, that it is, we can see it as part of being dangerous, but it also there's an opportunity for intervention. Now, the question is, what kind of things actually cause crisis? We have to highlight that just the fact that somebody has SUD does not necessarily mean that they will always have a crisis. SUD does not equate to a crisis all the time, even though we know that most of our clients sometimes experience crisis. The same is true with mental health, other mental health disorders. So let's now look at the course or the module objectives. In this module, we are going to identify at least 6 situations that can cause a crisis for clients. We know that there are many situations in our lives, even for the clients, that can cause cause crisis. And this is important for us to note in that we've already established that a crisis actually also has that subjectiveness to it. And therefore, it's not only 6, but here we are just saying 6 so that we can understand what a crisis is. We are going to also categorize the types of causes into 3 types. We will also have an opportunity to describe the cumulative effects of multiple causes of a crisis. Now, let's focus our attention to the possible causes of a crisis. Number 1 is lack of access to essential services and support. When we think about lack of access to essential services, we could think of essential services including employment services, housing services, food services for those that get food baskets. I know in Botswana we are having an issue where people were given food baskets. Lack of access to such services can actually create a crisis for an individual. And then lack of support. Support could simply be not having access to just talk to somebody. Support could be lack of access to communities to support services. Lack of support could be lack of support from family members, from church members. And I would want us to also be thinking about support when you think about recovery capital. So those things can actually, or lack of those things can actually lead to one having a crisis. The other possible cause could be poverty. Poverty, not having food, not having shelter, not only for yourself as a client, but even for your family, it can definitely cause a crisis. And sometimes I was thinking, there was a client of ours when I was working at one of the rehabs when I was in school, where they would come for all the services, but after all the services that were provided in the program, there was nowhere the person could go. So it was that towards the end of the day, the person was not concentrating in groups, and it was because they didn't have anywhere to go. So you can see the crisis that can emanate from the issue of poverty. There are many that you can think about when you think about poverty. Unstable housing, it also relates to what I've already said in terms of not having stability or with regards to shelter. The other possible cause of a crisis could be co-occurring medical and mental disorders. And I'm hoping somebody else can actually tell us in what ways can actually co-occurring medical and mental disorders actually cause a crisis for a client. Just quickly. How could co-occurring medical or mental disorders cause a crisis for our clients? Any volunteer?
I don't see any hands yet. And also,
Okay.
Marekwe, are you meaning to share your slides?
That's you guys are not seeing the slides.
Oh no, we're not seeing slides right now.
Oh really? You should have told me before. Okay.
At first I thought you were just doing an introduction to the slides, and I was going,
No,
wow,
no,
it's
no,
kind of going
no.
on for a long time.
No. Okay, so let me just share. Sorry about that.
It's all right, and Fernand's hand is raised.
Okay, sorry. Can you see the slide?
Yes, we can see it now. Sorry
Okay.
about that. I thought you
Sorry
were just
about
doing
that, because I was
story
going
time.
on and on. Okay, so the slides are here. So we've talked about what causes a crisis. So I was reading the objectives here. So we are on this particular slide about possible causes of a crisis. I'm sorry about that because I thought you could see. So yes, go ahead, Fatima, and tell us in what ways can co-occurring medical and mental disorders cause a crisis for our clients?
Okay, like I used to have a client that is a sickle cell patient. So, and he was abusing pentazocine injection. So most of the times he has, you see him having crisis because he is craving for the injection. So I don't know whether that crisis has to do with the co-occurring mental disorder, but I remember such as happened in my center.
So yes, sometimes our clients have debilitating medical disorders that actually cause crisis for them, right? You could also think about co-occurring medical disorders causing a crisis in that sometimes they have medical bills that they are not able to attend to. It can cause a crisis. Sometimes having mental or debilitating or very severe mental disorders can actually result in somebody losing a job. Let's say, for example, somebody behaving or somebody's behavior in a psychotic state can actually result in them losing a job if it does happen that they are in that state at work. So you can see how co-occurring medical and mental disorders can actually constitute to a crisis for our clients. Discrimination is one of the possible causes for a crisis. Victimization is also one. Family issues range from divorce. It could be family feuds, being estranged to your family members, and bereavement is one of those possible causes. We did discuss about stigma and discrimination, I believe, in cause 2. So we are not going to go back to the definition, but we've seen what discrimination does to our clients. That can definitely cause a crisis. It just reminds me of when I was doing a psychoeducation group, and there was one client who others were stigmatizing, and he realized what they were saying about him, and he was in a crisis because there was this issue of how do I make friends in this group because I'm stuck with them for about 6 weeks. And so it created a crisis for him because he could not handle being in the same group with those people. So victimization also is one of the possible causes of a crisis because it does cause trauma and it can lead to a crisis. We've already highlighted how mental health and SUD can actually cause or contribute to a crisis. So we are not going to have lunch. We are going to have, I know we have about 7 minutes, but I wanted us to actually quickly just go through this exercise. And I'm going to ask somebody from North Africa, right? We have North Africa. Can we have a volunteer from North Africa by just raising hand? A volunteer from Southern Africa, a volunteer from East Africa, and a volunteer, East Africa, North Africa, and then Southern Africa. So we are going to do an exercise for those volunteers. Fatima, Jessica, do we have volunteers?
I only see Fatima's hand raised at the moment.
Do we have somebody from North Africa to volunteer? Okay, can we have a volunteer from West Africa? Fatima is from West Africa, right?
Yes.
Okay. So what I wanted us to look at is the different categories of causes of a crisis. We have external factors. We'll leave the exercise. I'm hoping that when you are in your areas, you will have more time. We've already said that there are different categories of causes of a crisis. The first category is external factors. What are external factors? These are factors that actually happen to a client and they can cause or contribute to a crisis. They include bereavement, job loss, natural disaster, surgery, more especially when it's unplanned, imprisonment, terrorism, trauma, displacement from home due to conflict, civil unrest, war, other types of or severe loss. This list is obviously not exhaustive, but the main gist is that there are causes that are out of control for our clients that actually can cause a crisis. We also have internal distress. These are factors that are within, that resonate or that are within a client. Hopelessness can cause a crisis. Despair is one of an example of internal distress that can contribute to a crisis for a client. depression, because it's internal, suicidal impulses, psychotic or manic episodes, post-traumatic stress is one, unpleasant substance use reaction. So we have the second category that is for internal distress. I don't know whether anybody has any other examples of internal distress. One of the things that we have to pay attention is the fact that internal distress can actually lead to external causes of a crisis and vice versa. An example that I already highlighted earlier on about how somebody having a psychotic break or a manic episode at work can cause job loss. So here we are seeing a client having something that is internal, which is a psychotic or manic episode as a crisis, and that cause actually leading to an external cause of job loss that can actually, the two of them would be causing a crisis. So you can think of examples of how actually internal distress can actually lead to external causes and vice versa. The third category is transitional states. Transitional states are episodes or things that happen in our lives as individuals. Examples could be relocation. Relocation can be viewed as good, but it can cause a crisis if somebody feels that they do not have adequate resources actually to deal with. Marriage, often seen as a good thing, I'm guessing for most people, but it can be a crisis, especially when somebody is probably thinking they do not have the resources, or they become very overwhelmed by the whole idea of marriage and the ceremony and all that. A new family member or a baby, I know that's why sometimes women have depression after actually having a baby. So for some it's not a crisis, but for other people they can experience it as a crisis. Changing jobs for our clients, it can be a crisis, more especially that you see when people move in terms of recovery, that is a change in itself. So the more things that you put for a client actually can create a crisis for them. Retirement, it's one of the transitional states. People usually think that, when people retire, it's good. Even if it's good, it is a crisis in that you have to find meaning in terms of what you are going to be doing. Separation is also a transitional state. Divorce also can cause a crisis. When somebody experiences multiple events or internal states or multiple internal states, definitely it can lead to a crisis. Sometimes we have our clients actually having coping mechanisms to deal just with one event. However, when it's multiplied, it creates a crisis for them because they might not necessarily have enough coping mechanisms to actually deal with several events as compared maybe to probably one event. So that is all in terms of module 2. We do have 1 minute left, but I don't want to take more of your time. But we have covered what a crisis is, what causes a crisis, the different categories of a crisis. So we are hoping that when you do your trainings, when you do have time, you would actually do the exercises. They are more fun because you would have one group come up with their own list of the different or examples of the different categories that we've just talked about. I don't know, I can invite 1 or 2 questions before we move on to our next presenter. 1 question. Any questions before I stop sharing? And
I don't see any hands.
You don't see any hands.
Titlope, I believe, has her hand raised.
Yeah. Hello?
Yes, we can hear you.
Yes, my question is that I was thinking trauma will go for internal, not external. I want you to enlighten me more on that. Why the trauma go for external? Why not internal?
It can be both when you are thinking about because trauma is also subjective. It can be for the way that I see it, it can be both, because when you are thinking about a traumatic event, you are thinking about something happening to an individual, right? So that's why we've put it at external. But in terms of what happens in terms of your reaction to the traumatic event, definitely it's an internal issue. I don't know whether I've made it clear for you.
Thank you. Thank you.
Yeah, your response to the traumatic event is internal. When it's happening to you, then it's external. So thank you. Thank you. I'm going to let my colleagues continue where I left off. I know Moses, Professor Moses is next in terms of the guidelines to deal with trauma. Thank you, Moses. You can go ahead. Guidelines for crisis management.
Thank you, participants, for another interesting presentation. At this time, we are going to the guidelines for crisis management. Morocco has talked about crisis. He defined it, what causes crisis, and several factors, and how we perceive. It's not the event really, but our own perception of the event is what constitutes a crisis. So now we're going to the guidelines. These are the learning objectives. At the end of this module, we'll be able to describe crisis management, understand the 20 crisis management guidelines, and use the crisis management guidelines in practice role plays. We might not be able to do the role play, but we'll be able to go through the 20 guidelines. So what is crisis management? It offers those in crisis immediate help to solve the problems they are facing. Immediate help. That's what we should note at this time. It establishes balance or stability in a client's life. You know, we said when a crisis situation occurs, the individual, capacity to cope is overwhelmed, and the victim tends to lose balance. So in management, we try to establish balance or stability in a client's life. And it's immediate, short term, and time limited. So if you find this kind of thing in a multiple choice, and they say it's a long time, whatever, no, it's immediate, it's short term, and time limited. Assess, number one, assess available support. Identify and assess available help from family, friends, or other support. Maybe trusted group, sponsor, or clergy. And when we have anything to do with substance use, counseling, or whatever, you are always hammered on this assessment. You can't really help somebody if you don't assess the situation and get to know the person and what's happened to the client. You may not be able to help the client. But when you assess the situation and then what's available, particularly those of us in this part of the world where your family is, in fact, your source of insurance, social security, so on and so forth, then you know that you cannot really do without a family, except if the individual doesn't have a family. But even if there's no nuclear family or immediate family members, our extended family system takes care of such individuals. And then other supports that I can get from other groups. Involve family if necessary and possible. You try to involve the family, because if the individual is a crisis is being taken care of, eventually the individual is going to live with the family. And if the family is there, then the support will be strong. They will be able to help the victim through the situation. Provide or make referrals for family therapy or other community services if is not available in your own setting. So very important. Number two, you have to assess the risk. Assess whether the client or others are at risk. Is he really at risk of or a danger to himself? The crisis is constituting danger to his life or to the life of others. Is he at risk? Have program procedures in place for clients who indicate they plan to harm themselves or others. You have to assess and find out whether the client intends to harm himself or others. And then you know what your program or your treatment setting, says about what are the procedures, what are the guidelines. Then you be able to apply them to this crisis situation. Refer to appropriate mental health resources or hospital. If you're not in a treatment setting, then you need referral. If you think it's a crisis situation that is beyond you, please refer. Don't cause problems for yourself and for the client. Refer. Stabilize and refer. 3, meet face-to-face. Arrange a face-to-face interview with the client immediately if you can. Take precautions for the safety of both client and counselor. Sometimes it may be a telephone call and the client is in crisis. What do you do? Arrange for a face-to-face meeting. I had a client, a retired client who worked in one of the big financial sectors in my country. He was wealthy, but he had problems. He was drinking, and then he had problem and also had some depression. Somebody referred him to me, a distance of about 150 kilometers from where I live. One day, I had a phone call. Doctor, how do I say yes? How can I help you? I want to commit suicide. Then we got talking, and I'm thinking of 3 ways. If I hang myself, I'm so heavy because he was obese, the rope may snap, and I may just get some spinal cord injury or whatever, and I'll be incapacitated and become quadriplegic. Or if I drive my car and then go and crash it on a tree, I may not die instantly. And I don't want to live. I want to actually complete suicide. Or should I go and jump over a river? What about if I just fracture my neck and I don't die? So how can you help me? What way is the best? So I got talking to him, got him stabilized, and then I got a friend that I knew was close to him to drive him immediately, and they were able to drive to come, and then we met face to face, and I was able to intervene at that situation. That's how I saved his life. Face to face meeting is key if you can, but take precautions for the safety of both clients and counselor, because when they are determined, for instance, to harm themselves, if you stand on their way, then you'll go with them if you're not careful. Number 4, plan. Help the client make a clear plan for getting through the crisis. When you talk and when you intervene, ensure that at the end of your intervention, there's a clear plan for getting through the crisis. And the client has gotten the clear plan and satisfied that has a plan, out of the crisis. Because at that moment, they are confused, they are destabilized, and they cannot really think very well, articulate their thoughts and plan. So they need your help, your support to help them. It requires training, requires experience to handle some of these clients. Set time-related goals so that a plan for the next minute, hour, or even the next day, and involve significant others for support. Don't attempt to manage a crisis situation alone. Always get people to support you, maybe either colleagues or co-workers, maybe your supervisor, whoever might be, but don't handle crisis alone. Always get support because sometimes it can be dangerous. Number 5, set short-term goals. Crises are short-lived and the goals must be short-term. It's not planning for a long term, because if you plan for a long time, the client might not survive it if he's determined to take his life or if he constitutes a danger to himself and to others. Help the client set clear and achievable short-term goals. They must be clear and achievable. And enlist significant others to provide support. Is it family? Is it friends? Is it co-workers? Or counselors? Whoever might be there. Enlist significant others to provide support for the client. It's very important. Don't leave the client alone. And don't settle things only over the phone. Try to get, if you can't meet face to face, get people around who are close by to go there and assist. Normalize feelings. Normalize the client's reactions to the situation without minimizing them. You know, for us, I say, oh, he doesn't have faith. Is this a crisis? Why are you so cowardly in their behavior? What is wrong with you? That's the way people in my environment will react. You are not a serious person. You are a joker. No. Normalize the client's reactions to the situation without minimizing them. Because for him, it's a crisis situation. His coping mechanisms are overwhelmed, and you don't have to judge. You have to come alongside the client and assist, help, and support the client, and not to diminish whatever you do or minimize what the client is passing through. Because you can rather escalate that behavior, can rather escalate the crisis situation. And then actively listen without passing judgment. Remember, it's actively listen. You listen, don't interrupt, let them ventilate, let them tell you what's happening. Listen, ask questions, reflect, and affirm, and do so many things. Whatever weapons you have in your own arsenal, use them to support the client at this moment. But let the client have a feeling that you are listened, you are by their side, you are there to support them, not to condemn them, and you have been able to normalize their feelings. I will feel the same thing if I were in a situation. Most people will feel the same way. It's not something, out of the ordinary. So that they know that you are not thinking of them as people who are just crazy, or you are not judging them, or you are not looking down on them. So normalize the situation and don't pass judgment on them. Very, very important. Because here we tend to judge people, we come with our preconceived ideas, and because of the stigma too, we don't see them as people that deserve any attention, and we don't treat them with respect and dignity. We tend to treat them like people who don't deserve that, which is completely wrong. As a counselor, that would be unethical for us to do that. So understand the context. We keep saying, treat your clients in the context in which you find them. Not in your own context, in the context in which they are suffering. Understand what the situation means to the client. Try to empathize. Try to ask questions. Elicit information about personal, cultural, and social factors that may affect how the client views the situation. The client may be coming from a different culture. And to you, it's ridiculous what it is calling a crisis. To you, you don't see any crisis there. But you don't have to. Find out why that situation is a crisis to him. Why he is so overwhelmed by that situation. So if you have enough information about his personal characteristics or personal information about him, then his culture, the way the culture views such a situation, and then social factors, that will help so that you'll be able to appraise the situation, well, and you'll be able to assist. In my country, we have one country, different cultures. And sometimes the way people react to situation may even irritate you, because in your own culture, you don't behave that way. There's something that's not expected of you. And when somebody does that, then you become irritated. But you don't have to do that. If you know that he's coming from this culture and this is what it means to him, then you have to, as you said, calibrate your emotional barometer at 0, listen to him, empathize with him, and help him out, support him. Sometimes you find young trainees will do it another way, and in fact, they will even escalate the situation or worsen the problem. So you have to correct them. And sometimes they want to say, oh, you are very patient. Some will say, I don't have the patience to do that. I say, yes, you cannot be a crisis manager. If you don't have the patience, then you cannot be a crisis manager. You need to be patient and to listen to them actively to help. Sometimes I say, I can't do your work. I say, of course, you can't do it because you don't have what it takes, the skills, or you don't have the passion for it, so you might not be able to do it. Let somebody else do it. Explore coping strategies. Help the client explore effective coping strategies that were used in the past. They are not complete failures. They would have succeeded in many tasks before. So explore what they did in the past that was effective, how are they able to cope with previous crisis situations, and help them and remind them that they have what it takes. You can support them to overcome this one as well. Help the client identify past ineffective coping strategies, including substance use and why this did not work. Perhaps they were in a similar kind of situation and then they attempted to solve the problem using substances and it didn't work. Now that they're confronted with a similar situation, they are overwhelmed and they know that last time it didn't work, this time I'm in trouble. So listen to them, assess the situation, empathize with them, help them, and let them know why it didn't work. But you can use other strategies. You can help them use other strategies to help them, live through this crisis situation. What is the goal? Move the client from feeling like a victim to feeling empowered. If you're not able to move the client from feeling like a victim to feeling empowered, then you have not done much. You have not been able to actually help the client. You don't just take over the whole thing, but help them so that they will develop that sense of self-efficacy to be able to handle it. Tomorrow, when they face with another one, they may be able to employ similar strategies that you have given them or skills that they've acquired to be able to tackle future crisis situations. So always help them, to feel empowered. 9, focus on the here and now. Do not attempt to solve long-term problems. Crisis situations are short-lived, they're immediate, they need immediate attention. You don't postpone it and you don't begin to plan for tomorrow when you have a problem now to solve. So focus on the here and now. Focus only on the present. Don't think about tomorrow or next year when you have a problem to solve now that you are glozing over or you're overlooking. So, and what is important to the client now is the problem and the crisis situation. So resolve it now. Focus on now and here. 10, address physical symptoms. Address any physical anxiety and panic symptoms because when the heart is racing, when they become tremulous, they are sweating. Even the physical symptoms alone can escalate the problems. Oh, I'm dying. What's happened to me? I can't breathe. So you need to help them. Speak slowly and calmly. Help them to breathe slowly. Take a deep breath and breathe slowly so that they don't go into a state of hyperventilation. They don't escalate the problem because that will help them to be calm and encourage the clients to breathe slowly and deeply. And you, as a counselor too, must compose yourself. Be calm and calculated as you talk to them. Because if you are frightened, then it will only start to escalate the problem. Okay, my problem is beyond a resolution. I'm going to die or I'm in trouble. But be calm. When you are calm and you are collected, then you can also talk to them to breathe slowly and deeply. That will help, we will help them to be able to compose themselves. And instead of activating the autonomic nervous system, they'll be able to rather calm down. Because that is a psychological strategy for helping them to calm themselves down and not to go into a state of hyperventilation. And then they'll find out that some of the physical symptoms are resolved within minutes. So it's very important that to address physical symptoms. If they are not medically oriented people or if they are not really educated, the physical symptoms alone can aggravate the crisis or worsen the symptoms. Protect yourself. Now, number 11, very important. Protect yourself and do not take risks. Do not pretend to be a hero in this kind of situation, or a Superman. Protect yourself and do not take risks. Do not get between suicidal clients and a window or a ledge. Otherwise, the two of you may go. Because if the client intends to take his life or intends to take somebody else's life, and then you stand on the way, well, both of you will go. I'd like you to go. And call in a backup if you are dealing with an agitated or angry client. Get a backup. Don't attempt to do it alone. It's very, very important. Get a backup. Do not follow program guidelines. Every program, there must be protocols for handling situations like this. Every established program must have some minimum standards, some protocols, some guidelines, and in established treatment centers, you will even have crisis intervention teams that can handle crisis situations. So do not break rules. Do not physically restrain a client unless you have been specifically trained to do so and there is program policy allowing it. So that you don't run into trouble or you don't contravene the rules and regulations in attempt to help your client. Do not drive a client anywhere unless there is program policy allowing it. Some of my young trainees or counselors, sometimes become emotionally over-involved, and at times they want to rush, they want to drive clients. I said, no. Oh, we are social workers. Can we go? Oh, can we go for home treatment? We want to meet us. So it's a case you cannot, you dare not go there alone. In this environment, and you're a female, you cannot. I said, no. Until you get the right people and training to go there. Otherwise, you become a victim or casualty, and that will not speak well of the treatment center. So sometimes they can become overzealous, very enthusiastic, and then run into trouble. Do not drive a client anywhere unless there is program policy allowing it. And you must be sure that you can handle the situation. And if you have to drive, there might be maybe one or two others with you. Don't assume too many things. Don't want to play the role of a hero or a Superman, because you can run into big trouble and it can become very scandalous for you. So take your time and know what the program rules and guidelines are all about. In my own treatment setting, we have a crisis intervention team that actually are able to go even to homes, or they can even travel out of the city to other towns. If somebody is in crisis, they can rush there and get the person, attend to it. And if they need admission, then they bring it over. But it's only a team that has been trained to do it. You dare not go there if you are not, because you might get yourself in jail for nothing. 13, use a team approach. Never act alone when helping a client in crisis. We've said it, and call on your supervisor or a colleague to assist you. If you don't, you will learn the hard way if you survive it. Stay calm. Remain calm, collected, and in charge when interacting with the client. Don't be fidgety. Don't show any signs of fear or become anxious. Watch your own body language and how you conduct yourself, because if you don't, you might aggravate the situation. Be straightforward and direct. Do not give false assurances. Give evidence-based assurances. What is feasible, so that the client, respects you and, believes in what you say, and don't give them false promises or assurances that tomorrow they may discredit you or may not even believe in what you are doing. Though sometimes it's difficult in this environment that we work. People talk of faith, even when the situation is very dire, they want you to give some assurance. If you don't, they say you don't have faith. But as a counselor, you have to balance, the evidence with whatever faith, and look at the culture of the people and the context which you are practicing, and know what kind of assurance you're going to give your own client in crisis. That's very, very important. Do not confront. Do not assign blame. No, this is not this time to assign blame. Don't let the client think that you are not on his side but on somebody else's side. Because if they intend to harm themselves, then you will go with them. Reinforce that you are on the client's side in a crisis and that you care about the client's well-being. I've had several cases where clients come in crisis situation and in fact people ran away and they were confused, and sometimes they come with armed law enforcement agents. Even the law enforcement agents are scared because they said, in fact, they'll say, doctor, do something. They will call me by the side and say, I can't shoot him. And he's so aggressive, and I think he's stronger than I am. If you don't do anything, I will. If he attempts, to pounce on me, I will run away and leave you here. So, but you use your expertise, you use your skills, and you talk to them, and you find they're really calm. I've had similar situations where came in crisis with armed policemen and into a whole scene for people. But you use your skills and you talk to them very calmly. They say it's aggressive, you can't go there. I said, leave me to do my work. And then in the end, the client, calms down. You hold his hand and sit him down. Sometimes they come in shackles. You say, please take off the shackles. They say, no, he's aggressive. I said, take off the shackles. Take off the handcuff. Let me talk to him. Just take them off. They take them off and I talk to them. I tap them on the shoulder. How are you? I'm here to help you, whatever. And you find that they are calm. And then you hold the hand and you sit and talk to them and say, can we go? Let me assess you. Let me give you some help. And then they follow you. And then they think you're a magician. It comes with expertise. But you must know what you're supposed to be doing and you must be calm. So in our environment, people can come in all kinds of aggressive states. And the law enforcement agent say, run away. This guy is so violent. I said, just allow me to do my work. But sometimes when you do that, they begin to know that, okay, some people are trained to do this. Some people are experts in this. And they begin to admire the profession. In fact, one of our colleagues said he became a psychiatrist because in a battle, one of the soldiers was loaded. He had his own gun loaded and he was in a crisis situation. He almost pulled the trigger on them. But one mental health professional went, used his skills, and was able to calm the escalated situation, calm the client, disarmed him, and he said that's what made him to go into psychiatry to become a mental health specialist. So you need training for some of these things, and don't take this for granted. Be alert for relapse. Remember, clients with SUGs are more likely to use during a crisis. Yes. When they're in crisis, they are used to way of coping, even though it's maladaptive way of coping. They are used to using their drugs. At that time, they're likely to use drugs when they're relapsing, when they're in a crisis situation, and then they relapse. So substance use can worsen a co-occurring mental disorder. Remind clients of the risk of a return to substance use and that it has not worked before and it will not work. Remind them respectfully and they will understand. And they include relapse prevention strategies in planning. Be prepared. Be sure you know about and are prepared to mobilize appropriate resources. Law enforcement agents, mobile crisis services, if you don't have them, you can mobilize them. In our setting, we have a mobile crisis team that can go anywhere and attend to a client. Medical assistance and crisis treatment of mental disorders. Follow up. Develop a follow-up plan for the client once the crisis is resolved. You might have referred him, but you might still need him to follow him in your own facility. So you negotiate, and then with the consent, when the crisis is resolved, then you can take him over and follow him up and follow the client's progress. Very key. Take care of yourself. Manage your own level of stress. If you have a facility where you can debrief and then with your colleagues, then do that. Use self-care strategies that you know to take care of yourself. Otherwise, you might become emotionally overwhelmed and they begin to manifest some symptoms yourself. Or you can even get to a state of burnt out. It's very, very important that you use self-care strategies, especially for those of us who work also in the field of trauma. If you don't do self-care, you can end up becoming traumatized yourself. Maintain professional boundaries. Remember, maintain professional boundaries. Don't become emotionally over-involved and run into problems. Let others take the lead. If you do not feel comfortable handling a crisis, let others take the lead. As I said earlier on, some of my colleagues will tell me, I can't do this thing. I can't do this what you are doing. I said, well, I enjoy it. I have the passion for it. And I think I'm trying to do it and I can do it and I've been doing it. So, and I honestly respect them for being truthful that they don't have what it takes and they cannot manage it. Don't attempt to do what you cannot do. Crisis management is not for everyone. And that is very true. Forcing yourself to take the lead when you are not comfortable could have disastrous results and you might regret it for life. So this is very important. This is a role play, and you can do that if one person can play, can assume the role of a client who's in crisis, another one is a counselor, and then the other one an observer. You can do that in your spare time and see whether you are able to apply these 20 principles, of crisis management. It comes with training and it comes with experience and over time when you work in such situation. But crisis situation is not something that you take for granted. And if you are not trained, please call people or give it to somebody else who can do it. Thank you very much. I think we're going into into Beatrice's time. So
No
Beatrice,
problem.
please.
Thank
If
you.
you
You
have
only
question,
2 minutes. So you can stop sharing screen and then I can share mine. Thank you.
yeah.
Thank you. Thank you for that. So good evening, everyone. It's good to see you again. Thank you, Moses, and thank you, Morekwe, for that very good foundation that you have actually laid for me. I'm sure the participants have very many questions and comments, but we don't have too much time, so we're going to do a lot of interaction on the LMS around these topics of the day and this module, because it's actually extremely real. These are the things we actually face in the profession. So our module 4, we are going to actually look at a more serious crisis, the real crisis now. What do we do when the client presents with a crisis of suicide risk? That is what module 4 is about. And so we hope by the end of this module, we'll be able to have ideas on how we manage a suicide risk. So the first objective is that we want to describe the relationship between SUD or substance use and suicidal thoughts and behaviors. Secondly, we want to be able to identify the risk factors as well as the warning signs of suicide, which can be both direct and indirect. And then in the fourth objective, we want to be able to describe a 4-step process for doing intervention when you have suicide risk. And fourth, we're going to hopefully demonstrate how you apply this process using case studies. Now, this slide just tries to give us the magnitude of the challenge of suicide in the society. And it says that every year, about 800,000 people die from suicide, and the rate globally is about 11.4 out of 100,000 people, which basically translates to about 1 death every 40 seconds. Now that is sad, that's less than a minute. So as we speak now, and you can think about how much time we've spent in this class today, it means that we've lost several people because of the threat of suicide. And so this is a serious crisis we must think about. Now there's evidence to suggest that the risk for suicide is actually higher, especially among clients who are using substances, which is what makes this module relevant to us as practitioners in this field. And there are many reasons, which include the following. Many clients will use substances out of control, and Moses has been giving us exceptional examples from his practice. We have got substance-related life crisis, like we have been talking about the impact of SUD on our clients' lives and different areas of their life. We know that there are lots of crises that result from that. Many of them have depressive symptoms. Many of them may have other co-occurring disorders, including depression itself, PTSD, anxiety, and even personality disorders, including antisocial personality and borderline personality disorders. And then, of course, there are lots of stresses related to treatment and recovery. And Moses has given an idea. When they were using the substance, they used to cope by using the substance. When they start entering treatment and recovery, it's a transitional challenge. And you see, Morekwe has said that one of the challenges of or the causes of crisis is actually transitions and adjustments. So just because they've agreed to come for treatment does not mean that they are safe. The entry into treatment opens a lot of realities to our clients of the many losses they have in their lives and the many crises they have, and that can actually be a trigger for suicide risk. And they include issues of family readjustment, transitions between levels of treatment. There's evidence to show that if you look at the general population, this is in the US, individuals in treatment for alcohol abuse or dependence are 10 times greater at risk of suicide compared to the general population. At the same time, those who inject drugs are actually 14 times at greater risk of suicide compared to the general population. That then tells us that the environment we will find ourselves working, the risk for suicide is extremely high. Now, what are some of the risk factors? And this is important because when we understand some of the risk factors, then we're able to assess whether our clients are low risk, moderate risk, or high risk in terms of suicide risk. So one of the factors is prior history of suicide attempts. And it has been found to be one of the most potent risk factors. But it is also noted that despite that, about half of all suicide deaths are actually first-time attempts. And therefore, we can't say that if someone has never attempted, they will not necessarily attempt and complete suicide. But at the same time, when they have a prior history, then that's something to consider as a serious risk factor. The second one is the family history of suicide. It has been found that sometimes suicide tends to actually happen in families, maybe because of all this overlap with mental disorders, substance use disorders, which again run in families. The other factor is severe substance use, which is again makes us right at the heart of this problem because the clients we deal with have a lot of severe substance use issues. Other factors include the co-occurring mental disorders, which are listed here. It could be depression induced by SUD or just a standalone. It could be anxiety disorders, particularly those who have PTSD. It could be other severe illnesses like schizophrenia or bipolar disorders. It could also be personality disorders like borderline and antisocial. And this famous eating disorder called anorexia nervosa is also a high suicide risk factor. I don't know how common it is in Africa, but in the West, it's a big issue. Other risk factors include the history of childhood abuse, especially sexual abuse. It also includes stressful life circumstances. For example, if we have clients who have low levels of education, they have no job, they've continued being unemployed and haven't been able to find any meaningful work to do, that's a big stressful life circumstance. We have issues of divorce and separation that can actually lead people into stresses that can be a trigger to suicide risk. We've got legal difficulties. Sometimes we have our clients who've got all these legal cases around them, sometimes related to the substances, sometimes related to the negligence of duties related to substance use, among others. Then we have major and sudden financial losses. So maybe they lost their job, they lost their property to auction, social isolation and low social support. So you may find that clients may have been in a family, they got divorced or the family abandoned them. So they have low social support. And of course, conflicted relationships, whether it is families, whether it's in workplaces or critical areas of the client's life. Now, other factors include proneness to negative affect. We have got clients who are generally prone to negative affect. So they basically experience sadness, anxiety, anger. These are actually risk factors for suicide. Also, we have got clients who have got aggression and impulsivity. Those are other risk factors for depression. And of course, the last point is the issue of access to a method that is actually lethal or that could kill, such as gun ownership. Of course, there are many other methods that are lethal and that can actually kill, which our clients may have access to. Now, it's good to note that besides thinking about those factors, we need to be able to distinguish between suicide risks in terms of suicide ideation, suicide plans, and suicide behaviors. Those are 3 levels. So suicide ideation is where the client talks about thinking. They have thought about suicide. And these ideas may be fleeting, it's just once in a while, or they may be persistent. So the client may say that the whole day I keep thinking about this. There's a client of mine who said that he's been thinking about killing himself almost every day, in the last few weeks. Now that's persistent. So sometimes the ideas are fleeting, once in a while, occasional, sometimes they are persistent. The ideas can also be vague. Vague means they are not necessarily specific. Okay, I've been thinking I want to die, but specific ideas. But there are those who will tell you, I've been wondering, I've been thinking, what if I crashed my car on a highway? Now that's a specific ideation. And some clients will talk about specific thoughts. Then besides ideations, the second level is where we have the suicide plans. Now, plans are actually a sign of a more serious risk. And again, they could be vague and unrealistic. For example, the client tells you, I plan to shoot myself. But you know from their circumstance, they don't have access to a gun. Now, that's a vague and unrealistic sort of. But what if the client tells you, I think like the one that that Moses was describing, that I was thinking if I could tie myself around the rope to hang myself, I wouldn't die because I'm too heavy, probably. About how that is unrealistic. But what if they come up with another idea and say that they have got, like in my country, there is this, we call them poisons, poisonous substances which are used in farms, which are used for pest control. And a lot of people actually take the lethal ones as, the plans they have for suicide. So sometimes we need to listen to hear whether the client's plan is specific and feasible or practical, and it can actually cause death. Now, the third level is the suicide behaviors themselves. And we are defining suicide as an acute, deliberate act of self-harm, which results in death with at least some intention to die. Here is the point. It is acute. It is deliberate. So it was not something that happened unintentionally. There was intention. That is important, and it does result in death. That's why it's called a completed suicide. But there are many clients who will not complete suicide, but they will. We meet such clients, we want to think about, was their intention? How serious was the intention to die? To what extent did he or she expect to die? Because that will tell you how serious they are with their suicide behavior or ideation or plan. The second one is how lethal was the method that they used. I know that sometimes in my culture, clients will attempt suicide using methods that are not extremely lethal. And then families and community members and colleagues will make a joke about it and tell them, if you want to kill yourself, why are you using that rope that cannot kill yourself? I can give you a better method. So that kind of teasing, which is what Moses was saying, is not appropriate. And we need to realize that even if it's just an ideation or just an attempt or a plan, it is still something serious for us to think about. So when you're thinking about attempt, look at lethality. How likely was it that the behavior or that act was going to lead to death? That tells you about how serious it is. Now, the next and final part of this presentation, we're going to be looking at warning signs of suicide. We can have direct and we can have indirect. This slide is talking about the direct warning signs. What do they include? One, they include suicide communications. This is where clients talk about wanting to kill themselves. They will give oral threats to hurt themselves or to kill themselves. They will actually talk about wanting to die and communicate about it to someone. And every time I think about this statement, I always remember a neighbor of mine who told me that that her husband was having a relationship out of marriage, and how the other person was threatening to get married to the husband, and she had seen some messages on the husband's phone, and the other partner was saying that she doesn't mind coming in to take care of her children. And I remember this lady saying that, whose children? I can't allow that. I'd rather, something like, she said a statement like, I'd rather die, or I'd rather have all of us dead. She made such a statement. And believe you me, in about 3 months, that lady killed herself and her children. And now when I thought about it, that specific statement she made that day was actually full of meaning. It was just out of context. It was not in a treatment setting. It was just in a casual, social statement. But that suicidal communication is a critical warning sign of suicide. The second one is seeking access to a method. So the client may tell you that I've been, just like Moses was saying, I've been thinking about a rope, I've been thinking about pills, I've been thinking about hiring. There's a client of mine who told me they were thinking about hiring a gun from the cousin. Sometimes the students I work with in the university, I get messages brought to my office that a student has sent messages on social media saying that they want to hire a gun from their cousin who works in the military and they want to kill themselves. That is seeking access to a method. That's communicating about wanting to end their life. That is a serious direct warning sign. And the third one is when clients make preparations. Making preparations means giving away possessions, saying goodbye, sometimes writing a will. And this lady I was telling about that took away her life and that of her children, I was actually told the weekend before she called her cousin and told her that she had bought her all these nice things and she used to have a shop. And so she gave away her shop items to the cousin, but the cousin didn't think anything was wrong. This is really making preparations. So there are many signs that we can see and we see, but we don't think about them seriously, which could actually be important to warn us that something is wrong with the client. Now, we also have indirect warning signs. Indirect warning signs are less obvious, they are less explicit, they include ideation. So when the client tells you, sometimes I sit and I think I would rather die, or sometimes I'm driving and I think I should crash this car. There was a lady that I worked with, and she used to say the husband would tell her that when he's driving on a highway that's high up a place, he feels like he should just drive the car down that cliff of the road. Now that's ideation, but it's an indirect warning sign, but we still need to be concerned. The second indirect warning sign is when we have clients who use SUDs, which will actually be at risk of suicide. The third one is the sense of purposeless or meaningless. The client tells you, I no longer see the reason for living. I don't think anybody needs me anymore. I think my family can do without me. That sense of purposeless and meaningless is an indirect warning sign. The other one is chronic anxiety. We have clients that are chronically anxious. And I know when we looked at co-occurring disorders, we talked about anxiety disorders. And I have a feeling we may have mentioned clients with generalized anxiety disorder who are just chronically anxious, not necessarily for any one thing that you can put your finger on. Now, these are high-risk clients, and we need to watch them for these kind of signs. Others is when the client talks about feeling trapped. Clients, I met a university student who woke up and told the mother they were doing an engineering course that they want to quit going to school. Why? And when they came and we had a conversation with them, they said they were feeling trapped and nothing was just working out. So that feeling trapped means that they're just not feeling able to do anything and they're feeling helpless. That can be a serious indirect warning sign. Feeling hopeless, I think we know this a lot with clients with depression. Many with this feeling of hopeless. There's also the issue of working. When the client is a young man of the university was saying he didn't want to stay with any his own small space. He didn't want to be visited by anybody. That kind of social withdrawal and isolation can actually be an indirect warning sign. Chronic anger. These are clients who are aggressive and angry. Can actually be an indirect warning sign. Sometimes this could be related to SUD as well. Recklessness and impulsivity. So you might discover, or the client tells you, a member tells you they've been engaging in reckless driving or just reckless life. That could be an indirect warning sign. And then, of course, we have the mood changes or are aware about, especially when we think of our clients with all these conditions. So now, having done that, I want us to reflect, and this one we will not answer. Reflecting about suicide and culture. How does our culture view suicide? Are there any warning signs that differ from those we have discussed? What is your personal view? Please do this for your journal. And then allow me to quickly go to some little activity so that we can practice a bit about these warning signs. So I'm going to stop sharing this, and we are going to go to the trainer manual. And I believe that in your, but trying to see where I saved this so that we can do a case study. So this is actually a case. I hope that you can see it. We have several case studies in resource page 4.1. And I want us to see whether in the few minutes remaining, we can actually assess these three cases. These cases, we will try and do 2 of them. So there are 3 questions that I want you to think about. Thinking about those slides we have walked through, we're going to read this case study and we are going to look at the following, or for the following. 1, is there a direct warning sign, or are there direct warning signs in this case? Secondly, are there any direct warning signs? And thirdly, do you think this low, moderate, or high risk of committing suicide? Of course, whether low, moderate, high would depend on how many of the risk factors you see in the case, and whether ideation has planned, or even you can see their thinking concretely. So let's read the first case. Who's going to read for us the first case? Client number 1. And because I can see many of you, raise your hand, Jessica will see you. Yes, Fatima, please read for.
Okay. Katina is interviewed for
the screen.
Can I go on?
Yes, please.
Katina is interviewed for admission to treatment for prescription medication abuse, tranquilizers, and sleeping pills. During the interview, she reports that she was diagnosed with depression several years ago. Medication prescribed for her. She said she thinks that her family might be better off if she weren't around. She described her life as having no purpose except as a mother for her teenage children, but that they really anymore. Katina says she has decided to enter treatment because taking all the pills at once started to sound like a good idea, and that scared her. She also says she thinks about crashing the car sometimes when she is driving, not anyone else, and it also might be too painful.
Thank you very much, Fatima. So now, participants, I want you to answer question number 1. Are there any direct warning signs? And I hope you remember what the direct warning signs were. If you don't, they include communication about suicide, they include seeking access to a method, and they also include making preparations. So are there any direct signs with Katina? You may raise your hand.
Titi Lope's hand is raised.
Yes, Titi? So you can say 1 point. Jessica, you said whose hand was up?
It was Titi's. I will
Titi,
unmute her.
Okay, so Titi, please say 1 sign that you see, if you see any. Okay, maybe we can have another participant.
Right.
Alero, yes. Alero, please unmute yourself and give your contribution.
Okay, she was thinking of taking all the drugs at once. So she was making plans to take her life.
Thinking of
all
taking
the medications at once.
At once. So do you think that is a direct?
Yes, that's a direct sign.
That's a direct, all right? Do
Yes,
the rest of us agree? Anybody who has a different opinion?
Agreed.
Agreed. Okay, Samuel. Any other direct warning sign? Samuel?
I'm still thinking. I just have the indirect one.
No problem. Someone else called Mark says there are many warning signs. We must know what they are. Grace, please say your point.
To do with the driving, though she was also thinking of it.
Thinking about crashing.
Yes.
So was that direct or indirect?
It's direct.
You think it's direct?
Yes.
And And remember, we have said some of the direct signs are communicating, seeking access to the method, making preparations. And I want to remind you some of the indirect. Maybe we should ask a question too. Then we can be able to decide whether some of these are direct or indirect. So do you see any indirect warning signs? And I want to remind you what the indirect warning signs are. They include having ideation or ideas about suicide. They include using substances or being a person who is having an SUD, having a sense of meaninglessness or purposelessness, having chronic anxiety, feeling trapped, being hopeless or feeling helpless and hopeless, having chronic anger, being reckless, and also having mood changes and socially withdrawn. So here are some of the indirect signs you see with Katina. Any raised hands, Jessica?
Samuel's hand is raised again.
Samuel, please give your answer.
Okay, Beatrice, it's apparent that the feeling of hopelessness is there because she's saying that she feels the family are better off without her. Thank you.
So you're thinking there is a sense of hopelessness and that the family would be better off without her. So that is a sense of meaninglessness and purposelessness. Okay. Any other example?
I see a hand from Ajunwa.
Yes, Ajunwa.
I think the idea that might be a good idea.
Mm-hmm. So that's Thank you. So it's an idea. It's an idea, not yet an action idea. So but it's a very strong idea. Remember, we said the idea can be vague, they can be fleeting, but they can also be highly specific and persistent. So you can see this is someone who has highly specific ideas. And these ideas she has are actually ideas that can be lethal. For example, crashing the car can actually be lethal. Taking all the pills could be lethal. So she has got ideation, but the ideations are of highly specific methods. So that is real need for concern. Any other indirect warning signs that you see there? Okay, so do we think that this person is at low risk, moderate risk, or high risk?
High risk.
Yes, you can. Fatima?
I think she's high risk.
You think she's high risk? Why do you think she's high risk and she's only at level of ideation?
Yes, but her idea is so strong. She said she thought of crashing taking the pills at once may be okay. So I think she's in high risk section.
Okay. Does she have a concrete plan? This is for all participants, not just Fatima. Does she have a concrete plan?
No concrete plan yet.
Is there a concrete plan of how to do it?
No.
Not yet.
Yeah, not
all
yet.
Right. So I think this is still ideation stage, but the ideation is comprising of highly concrete sort of ideas, and that can be a risk. So where do we want to place her, participants?
It's high risk.
We put her at high risk.
Yes.
Remember we said the higher in the ladder you go, the higher the risk. And the ladder was comprising of ideation at the bottom, then plans, then behaviors, which include attempts. So this one is still at the level of ideation, has not started thinking of planning, although some of the ideas she has are very concrete and real. So we might want to think of her in terms of low to moderate risk. And I know we don't have time to look at another case. So when we go to the LMS, I'm going to ask you to look at these cases. And for each of them, we are going to judge what are the direct and indirect signs. And then we are going to be able to make some decision on whether we think that client has a moderate, low, or high risk. And we can interact more in the LMS to share what we can do about these clients. So thank you for your input. And now, because we've had a very heavy topic for today, I want you to do something called shaking it out. So can we now all shake it out? And I want you to do a little exercise in your space. Just do what it is that makes you feel good and shake it off. You shake it off. You can throw your hands, your legs, your head. You can stand up, and then you can remember some nice things that are happening in your space. If you're cooking something nice or someone is cooking something nice in your space, you can do that so that we shake off this feeling of all these things that we've been talking about. Think of one nice thing. Yes, I can see Fatima is actually shaking it off completely. We see someone else shaking it off. So can you speak so that I see you? Azu, where are you? Dr. Oko, can you speak and shake it off? I see it. Yeah, Ehigato.
Shaking it off.
Yeah, shake it off. Let's shake off
Shaking it
that.
off. Shaking it off.
Yeah, shake off this feeling of all these negative things we've been talking about. They are hard stuff. Thank you, Dr. Oko.
Give it a quick.
Thank you. So think some nice things now. Think some good things in your life. Think of the nice clients that you have helped and they have come out successfully, and get off this mood of all this negativity that we just got this evening because of the nature of material that we were working on. So thank you very much, participants. We shall continue engaging on. So I hand it over now to. Thank you, Jessica.
All right, thank you, Marekwe, Moses, and Beatrice, especially fun little ending we had there. So UTC 7 is pretty short. It's just going to be today and tomorrow. And one thing I did want to reiterate is I know some of you were having trouble finding the UTC 6 post test yesterday. Kim posted it a bit later in the day, afternoon for us, but evening for you. So if you have not completed that on the LMS yet, the UTC 6 post test is now available. And other than that, I hope you all have a great evening, and I'd like to open it to the presenters if they have anything to add.
Just to thank the participants for being very active participants in their time.
Sorry.
My teachers. Good night, everyone.
Thank you.
Good night, everybody.
Good night. Bye.
Good night,
Night.
everyone. Good night. Good night, everyone.
Good night.
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 Good night.
Night.
Good night.
Night. Night.
Night.